Hello, I'm Dr. I have no disclosure, but I want to give a context for this presentation, which is the last one in the course, and it'll help make sense as we proceed. The current standard of care for type 2 diabetes and insulin resistance really does not aim for or result in remission or reversal. That's not the aim. It's really more managing the serum glucose levels and managing the risk factors associated from hyperglycemia. Now, intensive lifestyle medicine interventions or intensive therapeutic lifestyle change is required for successful type 2 diabetes remission or reversal. Studies show that without sufficiently intensive interventions, it's just simply not possible to produce remission. And in addition to that, and perhaps related to that, there are few proven effective lifestyle medicine intervention programs available that produce type 2 diabetes remission. Now, of course, we've looked at many of them in previous modules in the course, and we will be talking about some of them in this module 16. And finally, there's no current reimbursement for type 2 diabetes intensive therapeutic lifestyle change treatment as there is, say, for intensive cardiac rehab for heart disease treatment. The intensive cardiac rehab services, Medicare services, are a good example of where certification and reimbursement is available for intensive therapeutic lifestyle change. We have 4 learning objectives. The first will be to review the format and structure of currently existing lifestyle medicine reversal programs. The second will be to discuss key considerations for the development of a lifestyle medicine program tailored to the reversal of type 2 diabetes and insulin resistance. And third will be to discuss the importance for rigorous tracking of outcomes for all patients and process improvement to optimize long-term successes. And finally, 4th learning objective will be to discuss reimbursement models suitable for lifestyle medicine interventions for type 2 diabetes and insulin resistance reversal. All right, let's start with our first learning objective, to look at the format and structure of currently existing lifestyle medicine reversal programs. We want to look here at lifestyle interventions with published evidence of disease reversal, and I've separated them into 2 types. We've got programs for heart disease and programs for type 2 diabetes and insulin resistance, and then there's a program that actually accomplishes both. So under the heart disease, we have the Ornish, Pritikin, and the Benson Henry intensive therapeutic lifestyle change programs. These programs are Medicare approved for intensive cardiac rehab. That means that Medicare recognizes them and you can bill for them and be reimbursed. They are residential programs, but also can be used in the outpatient treatment setting. They initially were tested and developed in a residential setting, however. They involve intensive execution and management. Of course, they are intensive therapeutic lifestyle change programs, but it also means that this is an intensive treatment. It is not what we might call modest. It is intensive. There's up to 72 hours of multifactorial lifestyle change treatment. I believe Medicare has both the 36-hour, in some cases, or up to 72 for intensive cardiac rehab. This must be delivered over a period of up to 18 weeks. They utilize a replicable franchised curriculum. Each one of them has its own proprietary curriculum, and they have been, at least the Ornish program has been franchised so that it can be used by others besides just Ornish. The Ornish program is now also being offered using telehealth. And then there's, interestingly, there's the Esselstyn Intensive Therapeutic Lifestyle Change Program. It's a different format and approach than the others we've looked at. It's a day-long intensive session with some pre- and post-sessions by telephone with Dr. Esselstyn and his patients. This is not a scalable or franchise program, but it does have strong levels of adherence. And there's a connection there because this is more like an individualized type of program. It's not like a franchised program where a intensive intervention, one size fits all approach is used. This is very individualized. And perhaps that's part of it, but the reason. But it is also not Medicare approved yet as an intensive cardiac rehab program. I believe the evidence is in the literature for it, that it could achieve approval. But when I asked Dr. Esselstyn about it, he said that wasn't something that was high on his priority list at this time. And then the Complete Health Improvement Program, or the CHIP program. This works both in the heart disease. There's 2 randomized trials looking at the CHIP program and cardiac risk factors. And there's also evidence that it has a significant improvement in blood sugar levels or hyperglycemia. It's a community-based in-person or an online intensive therapeutic program. It's scalable with especially the online version, but since it's DVD or downloadable video-based curriculum, it's scalable even in in-person community-based because you can have any number of programs running simultaneously. It has a variable intensity and duration, so it can be done as most of the ITLC programs. It can be done in a matter of 3 or 4 weeks, or it can be done over a period of 3 or 4 months. It is quite suitable for the medical setting. I've used it myself in a medical setting as a multifactorial intensive therapeutic lifestyle change program. It has proven effective intensive cardiac rehab intervention outcomes data. However, and it's also effective for type 2 diabetes management and treatment. However, it is not approved by Medicare because it did not publish data on the actual cardiac function. The data that's been published is clinically and statistically significant improvement in recognized risk factors, but they did not include echocardiograms or angiograms, and that is required, as we'll talk a little bit later, for Medicare approval. All right, let's talk about the format and structure of the existing lifestyle medicine programs for type 2 diabetes reversal. And really, the 2 main ones are the Counterpoint and the Direct Counterweight programs, both of them from the Taylor group in the UK. These programs utilize 3 phases, if you will. The first is a very low energy diet, and they have used a meal substitute, a liquid meal substitute during this very low energy diet. The goal during this phase, which may be anywhere from 1 to 3 months in length, is to lose 15 kilograms or about 30 pounds, 33 pounds to be more exact. And then there's a food reintroduction phase. It's typically about a month. And this is when the patients go from the liquid meal substitute to eating regular diet or regular food, I should say. The goal, and is carefully monitored and managed, is for them to adopt a weight maintenance diet with normal food. And it has been implemented in the primary care practices in the UK and Scotland. 2-year results were published last year, and some excellent outcomes and results. And then finally, I mentioned the CHIP program is also for type 2 diabetes reversal. So other programs for type 2 diabetes treatment would include things like the Diabetes Undone, which is quite popular in some circles. It's a video-based, so it's quite scalable. It's affordable, and it, however, does not involve any blood testing. It is coaching and health education or dietetic education, but it is not a medical program as such. It could, of course, be used as a curriculum by a physician or other medical person. Then there's the Mastering Diabetes course. It's online coaching and virtual groups. It's scalable, growing, actually, as I understand it, quite rapidly. People are having great success. It's run by a couple of people who have type 1 diabetes themselves. And so it has really been attractive to the type 1 diabetics. A lot of people are not aware, many doctors are, but not all, not so many in the public, that a type 1 diabetic often has insulin resistance in addition to their type 1 diabetes. You can greatly improve or reduce the amount of insulin needed if you can reverse their insulin resistance, even though at this point we're not able to reverse their type 1 diabetes. And this program does include labs, so it's another option. However, they have only one very small pilot study published in the literature, nowhere near the kind of publications that will be needed to be certified and to be reimbursable yet. Also, the WellStart Health is an interesting online program again that similar to Mastering Diabetes and Diabetes Undone, uses an online curriculum. It's scalable, it's affordable. However, there's nothing yet published on that as far as outcomes. Would be amiss if we didn't mention the Virta program. This is a high-fat keto diet intervention. And of course, this, as we know, high-fat diet has elevated cardiovascular disease risk, and they do not have yet long-term data on this program. They've published some 2-year results. However, the other thing is that the results that are talking about reversal allow the subjects, the patients, to continue taking a diabetes medication called metformin. So this would not qualify or meet the criteria established by the American Diabetes Association or other diabetes programs around the globe. It is scalable, and it does use a monthly subscription and a smart app. So there's some promising aspects with some serious concerns. Let's go to our second learning objective, talking about key considerations for development of a lifestyle medicine program that would be tailored to the reversal of type 2 diabetes and insulin resistance. As I mentioned somewhat in the slide on the context for this presentation, we still do not have recognized intensive therapeutic lifestyle change programs for reversing type 2 diabetes. We have to do this. These programs will need to be comparable to the intensive cardiac rehab services. I'm not saying it has to follow that same exact research approach and approval by Medicare, but we definitely need evidence-based, proven interventions, randomized clinical trials to the extent that lifestyle interventions can be randomized. And this has been done with the Ornish, Benson, Pritikin programs, so we know that it can be. So actually, the CHIP program has done randomized trials and may very well be one of the first ones that have sufficient data to prove reversal. We need rigorous outcomes data over multiple years. In other words, we need longer term follow-up than just a few months or even 2 years. 2 years is certainly good, but we really are needing things that may go for 5 to 10 years because, as is well known, rigorous outcomes data for multiple years of results and not just a short term. We need reimbursement approval for the intensive therapeutic lifestyle changes. We need to have a per hour reimbursement like intensive cardiac rehab. What we find is that for intensive therapeutic lifestyle change programs, a procedure-based billing like E&M coding for typical medical visits where you give a shot or you do some procedure. With intensive therapeutic lifestyle change programs, it is hourly rate as they did with the intensive cardiac rehab. It is the most suitable reimbursement approach. Also, we need certification. And the certification for these programs needs to be by recognized authoritative entities. For example, the Medicare carries considerable credibility and weight in the reimbursement of health services. And when they certified the intensive therapeutic lifestyle change programs and offered reimbursement, that was a very significant certification process. There are other certifications, and perhaps some of these could be useful as well. There's the American College of Lifestyle Medicine has recently announced a lifestyle medicine program certification using a scoring rubric that determines different levels of certification. There's the gold, the certified, or the honorable mention. And then there's also the National Cancer Institute that has established a number of years ago. They were one of the first ones to do this, actually, to establish a program certification for lifestyle interventions. They call it their research-tested intervention programs. And it was interesting because they did not, like the Medicare did for intensive cardiac rehab, the National Cancer Institute did not set any criteria beyond simply saying that there was valid research published about the intervention program. They call it their RTIPs, for research-tested intervention programs. And interestingly enough, I know that the Complete Health Improvement Program, or the CHIP program, has been certified as by the NCI, by the National Cancer Institute, for a number of years. And then the third certification we've already mentioned is the Medicare, Center for Medicare and Medicaid Services, ICR certification. This is specifically for heart disease. It's not for lifestyle treatment in general. It was focused specifically on heart disease. And we've mentioned that the Ornish, Pritikin, and Benson Henry programs are currently the only programs that have been certified by Medicare as cardiac rehab. So let's take a look at this, because as I mentioned earlier, this is probably the best practice model that we could learn from as we develop the certified intensive therapeutic lifestyle change programs for type 2 diabetes and insulin resistance reversal. The key prerequisites. So what they did was Medicare established prerequisite criteria to be able to be eligible for Medicare reimbursement. They use the G codes, they're called, which is a G followed by 4 digits as the code for billing. And only programs that have been recognized as meeting these prerequisites are eligible to submit billing. So if you're not one of the using one of those 3 recognized programs, you will get past first base, we might say. They required published proof of effectiveness in reducing the need for heart disease treatment, or published proof of improved cardiac function, and in addition to that, published proof of clinically significant improvement in 5 of 6 biometrics. Let's look at that more specifically, because this could be very useful in setting up our type 2 diabetes reversal. Medicare requires for reimbursement that the intervention produce one or more of the following. Must positively affect progression of coronary heart disease. So it must show that it's slowing or ceasing or reversal of the progression of coronary heart disease. It must it must reduce the need for coronary bypass surgery. So the criteria say someone would have met the criteria for having a bypass surgery. This intervention should be proven to produce regression to the point the person would no longer qualify or need bypass surgery. And or number 3, reduce the need for percutaneous coronary interventions or stent or other angioplasty. One or more of those. And then also it must show statistically significant reduction in 5 or more of the following items. Low density lipoprotein, so we would be talking about a statistically significant reduction. Number 2, triglycerides, again, statistically significant reduction in triglycerides, body mass index, systolic blood pressure, and diastolic blood pressure. And finally, number 6, the need for cholesterol, blood pressure, or diabetes medications. So a decreased need for statins or a decreased need for blood pressure medications, beta blockers, calcium channel blocker, and diabetes medications. And since there's 5 out of 6, for example, need not. It is not necessary if the program meets the first 5 here you do not have to meet the 6th one, which is the need for medications. All right. Let's turn to our third learning objective, which is to discuss the importance for rigorous tracking of outcomes for all patients and process improvement to optimize long-term success. So the first thing in tracking outcomes is that we must, of course, track the remission measures, the measures that that have been established and recognized as determining if remission has occurred. And according to the 2009 BUSE article in Diabetes Care, that would be the hemoglobin A1C and diabetes medication dosing. Those are the two criteria that have been established. In fact, the European Association for Diabetes also uses the same, an A1C and medication dosing as the criteria for remission. We are adding to that measurements of insulin resistance, which the most common and prominent one would be the homeostasis model of assessment insulin resistance, or HOMA-IR. This is because we're also talking in this course about reversing insulin resistance. There is good evidence that we've talked about in previous modules showing that insulin resistance is present without there being type 2 diabetes, and it has negative effect on many other conditions and comorbidities. So it is something, even if a person does not actually have frank diabetes, but they have insulin resistance, it is beneficial and desirable to reverse it. And then secondly, we need to track related comorbidities, those comorbidities that are specifically tied to, and we know our diabetes is a risk factor for. So we're talking here heart disease and stroke. Having diabetes is considered a risk factor equivalent to having had a previous event, heart disease or stroke event. So it's a serious risk factor, and we should track these comorbidities along with the diabetes. The risk of having hypertension, or the likelihood of having hypertension, is greatly multiplied when the patient has type 2 diabetes. And then there would be other biometrics that we should always track for lifestyle interventions. So we'd be talking about BMI, lipids, blood pressure. Of course, they would be tracked for the heart disease and the hypertension as well. So we need to also track medication dosing. And here we're talking not only about type 2 diabetes or diabetes medication, but we're talking about all medications, because one of the things about lifestyle intervention programs is they are multifactorial. They produce improvements in all morbidities, and so we can demonstrate oftentimes a savings from the intervention because of improvements in other conditions as well as the target condition. We also want to track lifestyle practices. Here we'd be talking about the 6 pillars of lifestyle medicine, or the domains of lifestyle medicine: diet, exercise, sleep, stress, etc. We also recommend that tracking quality of life using either something like the World Health Organization Quality of Life Brief questionnaire or the RAND Standard Function 36. They have both been validated and tested. The measures are suitable. There's not question about whether they are actually measuring quality of life or not. And we need to track long-term outcomes. This would be usually follow-up by the primary care provider or others, and we'll touch on that a little bit later in the presentation. We need to also keep in mind the importance of data integrity. It is important not to massage the data, as often said, or the term is used. What we're talking about here is when we collect patient data and we examine it, it is without a hypothesis, a priori hypothesis, meaning before we collected the data, we decided what we were going to measure, what we were going to look for. When we go to looking at it after it's been gathered and we did not have a defined purpose because of the randomness of results, it is oftentimes that we will draw a conclusion that is not warranted. Anyway, it's important not to massage the data, and it's also important not to talk or measure only the champions. Measuring what we call champions, or the ones that have the best results, does not show us what is probable. It shows us only what is possible. It can be useful to show the potential, but it doesn't give us any prediction of what the typical patient's results will be. So we have to collect data on every patient and not only champions. We also need to predefine, as I mentioned earlier, predefine the measures that we're going to track and report on. When it comes to for example, with the intensive cardiac rehab services, Medicare specifically told them what things to track, as we discussed earlier. Well, we need to have a set of measures defined, and that's what the previous slides were about, suggesting what we would track with a type 2 diabetes remission program. It's also best to use independent third parties to collect, analyze, and report these outcomes. It's labor saving in one way, but it's also important that we have some distance or separation between those who are doing the treatments and those who are evaluating and analyzing them. It adds to the integrity and reliability of the analysis. Another thing that's very important is process improvement. No matter how good the program that we have developed is, it can always be improved, and we need to continually review outcomes and inputs for all patients. And this is where analyses, not for the purpose of reimbursement or of certification, but for the purpose of quality improvement, is so important. And here we cannot always define ahead of time what questions we're going to want to examine for process improvement. So we don't worry here about a priori hypotheses. We actually are just looking at relationships between what we're doing for the patient during the treatment and outcomes to see where the treatment effects are being produced. And is there anything that we're doing that's counterproductive to our goal? We also need to stay abreast of research literature and try new interventions. One that many are now examining and using is the fasting mimicking diet. This has been talked about in previous modules during the course, and this is something new that's quite promising, with the possibility of making real differences in pancreatic function. And we need to use qualified independent third party where possible to do the data analysis, because they have an objectivity that is very important. So now let's look at our fourth and final learning objective, to discuss reimbursement models that were suitable for lifestyle medicine interventions for type 2 diabetes and insulin resistance. We've looked at the intensive cardiac rehab requirements for Medicare, but we need to look at payer-specific requirements to qualify for reimbursement. Most payers will have criteria that are published, or they will certainly identify for you what the provisions are that would make it suitable for them to reimburse the treatment. So there's three broad areas that we want to look at here. We want to talk about self-insured entities. We want to talk about self-pay services or direct pay, and then third-party payers like Medicare or Blue Cross Blue Shield. Self-insured entities, let's talk about that just a bit. What is a self-insured entity? Because they come in different sizes. Last week, the shared medical, another important thing to keep in mind, we touched on it earlier, is long-term follow-up. Intensive therapeutic lifestyle change programs like, for heart disease, the intensive cardiac rehab is anywhere from 4 to 18 weeks of treatment. But we want to see results over the long term, and that requires follow-up even though the treatment has finished. So the typical way of doing this would be with shared medical appointments. You can have drop-in appointments where anyone who's been through the intensive program can come, let's say on like the second Tuesday evening of the month, and there's always, it's like an AA meeting. It's open. Anyone who's been through the program can come for a follow-up visit and get measured. We would do biometrics, etc., and just track there over time. Chronic care management is another approach to this. There's a variety of chronic care management tools out there and approaches. Another one would be telehealth services. Could have virtual visits by telehealth, and again, it could be open meeting like a Zoom, where anyone with the password and the password would simply be evidence that they've been through the program, could come on and to the meeting. Another would be remote patient monitoring. This is quite interesting technology being developed, and it's becoming more and more practical to do this, to monitor long-term progress. And there's the intensive behavioral therapy. For example, this has been approved for obesity and for cardiovascular disease. And the lifestyle medicine team members can bill also for their visits on this basis. So, in summary, we've reviewed the format and structure of existing lifestyle medicine. Thank you so much for